Good afternoon and welcome to this ERKNet webinar. My name is Francesco M and I'm speaking from my office in Rome. As always, before starting, I remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the GoToWebinar application that appears on your screen, and I will ask your question at the end of the presentation. The webinar will last approximately 30 minutes. We will then have 15 minutes available for questions. Our speaker today is Professor Fadi Fakhouri. Fadi Fakhouri is an adult nephrologist and a clinical researcher. He has a long-standing interest in autoimmune renal diseases and in particular in complement-mediated nephropathies. He has conducted several clinical and experimental studies in the fields of thrombotic microangiopathies, C3 glomerulopathy, and other membranoproliferative glomerulonephritis. The title of his lecture today is Pregnancy-Related TMA. Please, Professor Fakhouri.
Thank you, Francesco, for the invitation and the nice introduction, and thank you to the ERKNet. So the topic today is pregnancy-related TMA, and as you all know, pregnancy is a high risk for various forms of TMAs or TMA-like disease, starting with TTP, thrombotic thrombocytopenic purpura, and going up to postpartum bleeding, and of course preeclampsia and eclampsia. It's relatively a frequent disease, but its frequency may vary depending on the clinical setting in which you practice. So my first question is, how many cases of pregnancy and postpartum TMA have you seen in your career? Less than 5 cases, between 5 and 10, or more than 10 cases? We will wait to get everybody's answer.
Can you see the answers?
I can see them. I can see them.
Okay. So when you see the answer, that means that the poll is closed, so you can go ahead.
Okay, I don't see it yet.
Okay, so 84% have replied less than 5.
Yeah.
12% between 5 and 10, and only 4% have seen more than 10 cases.
Yeah. So, in your point of view, it's a rare disease, and I agree that if you stick to what we call pregnancy TMA, in our mind it's almost TTP and HOS, it's a rare disease. But if you take the whole spectrum of pregnancy and postpartum TMA, they include preeclampsia, eclampsia, and HELLP syndrome, probably taking this into account, we'll see more frequently cases. But today we're going to focus on HOS and atypical complement-mediated HOS, hemolytic uremic syndrome, and the link of pregnancy is rather obvious. As I told you, first, pregnancy triggers a lot of forms of TMAs, and second, complement in pregnancy has a long-standing history where complement activation occurs during pregnancy and is helpful in order to get the egg implanted. But it needs a tight control. And from animal models, we know that the loss of the control of complement activation will lead to fetal loss. So complement activation occurs during pregnancy, especially in the early stages, and it requires a tight control. So if you combine a high-risk period and complement activation, you will, of course, understand that pregnancy and postpartum and atypical complement-mediated HOS have a lot of important interactions. In the last 10 years, our perception of pregnancy hemolytic uremic syndrome have changed following a couple of studies. The first was conducted in Europe between Italy, France, and UK, and included 87 cases of patients classified clinically as having pregnancy and postpartum hemolytic uremic syndrome. And we found that a majority of patients have HOS during the postpartum, at least after the delivery, and a minority during pregnancy by itself. And we have also seen that the HOS can occur during any pregnancy, of course, during the first, but also second or the third, or even the fourth. So it's unpredictable when a woman, for example, with a history of HOS, will have a relapse or not of HOS during a subsequent pregnancy. And of course, we had a very severe presentation because dialysis was required in almost 3/4 of the patients. Platelet count, thrombocytopenia was rather mild, and extrarenal manifestation with a rather strict definition were present in 15% of cases. So patients underwent plasma exchanges in 80% roughly of patients, and some of them received specific treatment. We'll discuss treatment a little bit later. All I wanted to point out is that HOS in pregnancy and postpartum have a similar presentation to complement-mediated atypical HOS not linked to pregnancy and postpartum. And this was also true when we studied the follow-up of this patient when 1/3 reach end-stage disease within 3 months of pregnancy and postpartum, and roughly 1/4 had a relapse of HOS during follow-up. Once again, very similar to complement-mediated atypical HOS not linked to pregnancy and postpartum. And finally, these patients had a relatively high frequency of complement gene variants in C3, factor H, factor I, factor B, MCP, whatever. We have the list here. 56% had at least one variant in complement gene. Once again, like any complement-mediated HOS not related to pregnancy or postpartum. So you have another retrospective study from Spain showing this roughly the same. Predominance in the postpartum, high risk of dialysis, high risk of end-stage disease, and similarly, a relatively high frequency of complement gene variant. So this has led to a reclassification of pregnancy and postpartum HOS. It was classified within the secondary TMA group, and now it is classified rather in the pregnancy, postpartum HOS is classified within the complement-mediated atypical HOS. So how should we treat it in this case? It should be treated like any other complement-mediated atypical HOS with complement blockade, with C5 blockade. The only available currently is eculizumab and ravulizumab in the coming months. You have no prospective studies, of course. It's a rare disease, and on top, you deal with pregnant women. But of what we know of published cases, is that eculizumab is efficacious in treating pregnancy and postpartum atypical HOS, like any atypical HOS. Of course, you may have the bias of positive results published, but still, the overwhelming evidence shows that, like any atypical HOS, complement-mediated pregnancy and postpartum associated atypical HOS responds well to C5 blockade with eculizumab or ravulizumab. We have not a lot of data with ravulizumab, but at least with eculizumab. You have to keep in mind that eculizumab during pregnancy is not a guarantee that the pregnancy will be uneventful. Doesn't guarantee. It's not a full guarantee that preeclampsia and eclampsia will not occur. And this has been documented in this small number of pregnancy under eculizumab in patients with atypical HOS. The second is that during pregnancy, you need higher doses of eculizumab or shorter interval between infusion in order to keep a rather complete complement blockade, let's say CH50 below 20%. These 2 points have to be kept in mind. So when you discuss all these points, it may seem very straightforward. Pregnancy, postpartum HOS, it is a very severe disease, requires urgent treatment with complement blockade. The problem is that it is very hard to distinguish in some cases pregnancy and postpartum ATP-HOS from the other forms, more frequent forms of pregnancy and postpartum related HOS. Of course, if you have a patient with uneventful pregnancy, uneventful delivery, and who 3 or 4 weeks later presents with full-blown TMA, very severe acute kidney injury, mild thrombocytopenia, it's very, very likely it is ATP-HOS. But you have a patient who had some hypertension, low-grade proteinuria in the beginning, plus postpartum hemorrhage and develops TMA, it's going to be sometimes very hard to distinguish ATP-HOS from preeclampsia or from postpartum hemorrhage. So, how, in your practice, how do you diagnose pregnancy-associated HOS among the other forms of pregnancy and postpartum related TMA? This is the second question of the call. Still waiting for the results.
So I take it that you cannot read them?
No.
Okay, then I'll read them to you. So 22% is based on complement test, 7% on pathological data, and 71%, so the vast majority, by excluding other causes of TMA.
Thank you, Francisco. So, to be honest, today we have no 100% reliable test for diagnosing, positive diagnosis of pregnancy-associated HOS. So it's C. We diagnose pregnancy and postpartum HOS once we have excluded other causes of TMA, once again, with a reasonable clinical probability and a reasonable time frame. Why is this? Why do not use complement markers, activation markers for diagnosing HOS? Because they are not reliable. If you take a cohort of HOS patients, not necessarily related to pregnancy, and you measure their, let's say, C3 serum level, half of the patients have normal serum level of C3 despite having full-blown complement-mediated HOS, including patients with very pathogenic variant. If you take another marker, very trendy one, soluble C5b9, similar things, you have a wide overlap between normal controls, healthy individuals, and patients with HOS, and you have also high variability from one cohort to another. So you can't rely on it. Normal results does not exclude atypical HOS, and even elevated results, for example, if you take preeclampsia, or if you take bleeding, severe bleeding postpartum, it would be surprising if you don't have high levels or elevated level of soluble C5b9. You have new developed tests in vitro that may help you tell if your serum will lead to deposition of complement, mainly soluble, soluble C5b9 on endothelial cells. But once again, these tests are not fully ready to be implemented in the clinical routine, and they need to be replicated because before we can translate in clinics the results of in vitro tests. So it's sometimes very difficult to distinguish atypical HOS from other causes of pregnancy. This is why we set up an international working group on pregnancy and postpartum TMAs, and we gave some general guidance how to distinguish atypical HOS from other forms of pregnancy and postpartum TMA. It is based on some very basic findings and observations. The first is the context is very important. If you have a severe delivery hemorrhage, the patient has lost over 1.5 liter of blood, had massive transfusion, it is very, very likely that TMA is mostly related to this bleeding than TTP or HOS. Of course, very rare cases being excluded. The second, you have to keep in mind that HOS as TTP are rare disorders in general and during pregnancy, and that probability pleads more for preeclampsia, eclampsia, and HELLP syndrome than atypical HOS. That is the third point. Preeclampsia, eclampsia, and HELLP are still the main cause of pregnancy TMA. Fourth, as I said, there is no positive diagnosis text for atypical HOS. We dose complement, we do genetics, but you can't rely on them in the acute setting for diagnosing atypical HOS. 5, a pregnancy associated HOS or TTP presenting as HELLP, well, it may occur, but you have to keep in mind that it's very, very rare. 6, increased level of serum liver enzymes are extremely rare in atypical HOS. 7, the absence of thrombocytopenia does not rule out pregnancy-associated atypical HOS. This is also true in any HOS. 15% of adults with HOS have normal platelet count. And HELLP syndrome is in the majority of cases not a TMA in the kidney. If you do kidney biopsy in patients with acute kidney injury and HELLP syndrome, they usually have acute tubular necrosis and not TMA. Preeclampsia and HELLP syndrome, despite all animal data, despite pressure by any group towards using complement modulators in HELLP and preeclampsia, today they are not predominantly complement-mediated TMAs. And 10th, spontaneous evolution of renal hematological parameters during the first 48 hours after delivery is crucial in the management of pregnancy TMA. You have to relax a little bit when you are facing pregnancy and postpartum TMA. The atmosphere is usually very stressful, but you have to keep calm and take 48 hours. If there is no neurological signs of cardiac involvement, I will go back to this a little bit later. 11, you have to keep in mind that the benefit of plasma exchange is only proven in ADAMTS13 deficiency-related TMA when you have antibodies and you have to give back the ADAMTS13 activity. There is no benefit proven in preeclampsia, eclampsia, HELLP syndrome, postpartum hemorrhage-related TMA, and no clear benefit, of course, in HOS. In case of anuria, especially in the context of postpartum bleeding, the major diagnosis to rule out is renal cortical necrosis. By using Doppler, IRM should be ruled out, because if you have widespread renal cortical necrosis, you know that the chances of renal recovery are not so high, which will lead for going for just symptomatic treatment. And you have to keep in mind, when the patient's condition, when the overwhelming stress of the medical team and the treating team and of the patient allows it, and platelet count allows it, a kidney biopsy may be helpful. For example, in the setting of HELLP syndrome, you have HELLP syndrome, you are wondering if you have a TMA in the kidney, you do a biopsy. If you have only acute tubular necrosis, it will help you calm down and wait just for the recovery of renal function. We also gave, I admit it, a rather complex algorithm for diagnosing atypical HOS, going step by step and excluding other forms. So I have simplified it a little bit. You have to keep in mind to have ADAMTS13 activity to rule out or in TTP. And if you don't have it in routine, you can rely more or less, but usually it's more than less, on serum creatinine and platelet count. Serum creatinine below 200 micromoles, platelet below 30,000, it pleads a lot, it points a lot towards TTP and not HOS. The second is, of course, preeclampsia and eclampsia, and soluble FLT1 PLGF ratio may be helpful, especially if it was monitored a little bit before the development of clinical signs. It may be helpful if it's available. And of course, you have the setting, the liver enzymes, and the ratio I have already discussed. Postpartum hemorrhage, once again, a lot of bleeding, a lot of transfusion, sometimes tranexamic acid use. It it suggests that is TMA related to hemorrhage plus minus tranexamic acid, and you have to rule out renal cortical necrosis. And of course, you have to keep an eye on autoimmunity with some very simple tests. And if all this have been excluded, you can diagnose by exclusion atypical HOS. Once again, complement tests are not required in the urgency setting. They are done, usually done, but you can't rely on them. I would say in any atypical HOS, in the acute phase, the only test would be valuable is anti-factor H antibodies, because it points towards an autoimmune process and maybe suggests that in some situation you will use immunosuppression. But I'm not aware of a lot of cases of postpartum and pregnancy HOS related to anti-factor H antibodies. So once you have diagnosed atypical HOS, so this is question 3. I will change it a little bit. How do you treat, let's say, atypical HOS? Pregnancy and postpartum related atypical HOS. Forget TMA. Let's focus on atypical HOS. Plasma exchange, delivery, C5 blockade, or no specific treatment.
All right, so let me read you the answers. 10% have chosen plasma exchange, 22% delivery, 54% C5 blockade, and 14% no specific treatment. So, okay.
Go ahead, sorry, go ahead. I interrupted you, go ahead.
I was just summarizing so that about half of the voters have chosen the C5 blockade.
Thank you, Francesco. I changed the question, so maybe it misled you. We have also proposed in the working group a treatment algorithm. Once again, it's a little bit complicated, so I'll try to simplify it. As I told you, if you have no women with a pregnancy or postpartum TMA, you have to ask yourself whether it's typical preeclampsia, eclampsia helps them. If it's yes, you go straight to symptomatic management, delivery, and close monitoring. If you don't have clinical evidence that is preeclampsia, eclampsia, and HELLP syndrome, and if you don't have neurological or cardiac symptoms potentially related to TMA, we recommended close monitoring in ICU during 2 to 3 days and see what happens. It will give you also some time to exclude sepsis and autoimmune disease. And of course, once again, if you have massive postpartum bleeding, you have to rule out or in renal cortical necrosis. If after this initial phase of monitoring, you have an improvement in thrombocytopenia, hemolysis, and more than 25 decrease in serum creatinine, well, you can relax a little bit and say that HOS and TTP are probably unlikely and continue monitoring. If it's not the case, you start plasma exchange with fresh frozen plasma till you wait for ADAMTS13 activity. Here, plasma exchange are started only to avoid not treating TTP if it is TTP. So if you have a confirmation that it is TTP, you continue plasma exchange. If not, and you have excluded all the other causes of TMA, you go for atypical HOS, discontinue plasma exchange, and switch to anti-C5 therapy. And of course, if you have initially had the diagnosis, neurological or cardiac symptoms, not related only to hypertension, if you have a PRESS syndrome, not just related to severe hypertension, it's not worthwhile starting plasma exchange. You have just to control hypertension. But if you have symptoms potentially related to TMA, high troponin level, some form of cardiac dysfunction, or neurological signs not related to hypertension, you may start directly plasma exchange in fresh frozen plasma, and the rest is the same, whether it is ADAMT-associated activity is detectable or not detectable. So just I added one slide on renal cortical necrosis. You have also recent series from France, around 18 cases. It's a rare occurrence, but you can't miss it because it's not useful to go in very aggressive treatment if you have extensive and almost complete renal cortical necrosis, especially in the setting of postpartum hemorrhage. So the last point I would like to discuss is how you counsel a patient with a history of atypical HOS who wishes to start a pregnancy. As you know, with the use of anti-C5 blockers, patients recover almost normal renal function, but at least very acceptable renal function, and the issue of pregnancy is discussed sooner or later. So the first point is pregnancy is no longer contraindicated in women with history of HOS because the risk of relapse is highly unpredictable. A patient may have full uneventful pregnancy and have a full-blown atypical HOS during the fifth. So the risk of relapse is difficult to predict. Of course, you have to, it's not, if the patient is in acute HOS or in the first 3 months of treatment with of HOS with eculizumab, it's not the right moment to start a pregnancy. You have to have some sort of remission, long-standing remission, and in some cases, it's almost CKD or clinical or infraclinical renal damage, especially in vessels, that is more a limitation to pregnancy. Of course, the patient has, as a consequence of an acute HOS, some form of CKD, severe in some cases, even it has become rare, but still it may happen. It's more a limitation to pregnancy than the risk of atypical HOS by itself. We did not advocate prophylactic anti-C5 treatment based mostly on the highly unpredictable risk of relapse, but we suggested, of course, prompt treatment, even if you have only some minor signs of a potential HOS relapse during pregnancy. And of course, pregnancy in women with a history of atypical HOS remains a high-risk pregnancy that requires a very close monitoring by multidisciplinary treatment. So you have started the patient on anti-C5 blockade for pregnancy and postpartum, let's say a postpartum HOS. For how long you are going to keep it on anti-C5 treatment? A couple of months, 6 months, it depends on the patient, during her lifelong, or you never use anti-C5, so you don't care. Sorry, Francesco, I'm going to annoy you once again.
So you have a majority of attendees that have responded that it depends on patient characteristics. That's 53%. About a third, 36% would give it for 6 months. And then 6% will give it for 1 or 3 months or lifelong.
Okay. Thank you, Francesco. I have to agree with the majority. So what is optimal treatment of anti-C5 with anti-C5 blockers in pregnancy and postpartum? It's the same issue, and it's more and more frequently raised issue, a question in HOS in general. So I'll give a general answer that will probably also apply to pregnancy and postpartum. It depends on patients. We have recently published with Véronique Frémaux-Beki and Chantal Waha a prospective study from France in children and adults. So I'll focus on adults because they are more concerned with pregnancy and postpartum, obviously. We had 36 patients, adults, who discontinued with treatment, and 13 relapsed, and only 7 adults. But the major information is that the risk of relapse, like in smaller retrospective studies, depends on the presence or absence of complement gene variant. If you have a very pathogenic complement gene variant, let's say factor H, the risk is around 50–60%. But the main message of this trial is that if you don't have a variant, the risk of relapse is very low, below 5%. In this study, only one patient relapsed without having any complement gene variant. It was a child. And it turned out that it was a misdiagnosis of atypical HOS. It was ADAMTS13 deficiency related TMA. So I would say on the opposite, if you have a patient with no complement gene variant, you stop anti-C5 treatment and he or she relapses, maybe you should check the diagnosis too. But still, and the second information we got from this, we have variant, no variant. This is in adults. When you have no variant, you have no risk of relapse. In this limited duration of follow-up, I agree. And the important thing we found also is that within the group of patients with complement gene variant, if you keep a soluble C5b9 level high, below the upper limit of normal, during treatment with eculizumab, is also associated with a higher risk of relapse after treatment discontinuation. So it will help also counsel patients who have a complement gene variant. So I would say 6 months or till stabilization of renal function, and then you discuss. No complement gene variant, discontinuation is rather safe and advisable. Complement gene variants, case-by-case basis to discuss. So in conclusion, complement and postpartum HOS is a complement-mediated atypical HOS, but its differential diagnosis remains challenging when specific treatment has become urgent. So 10 years ago, whether it was HOS or not, everybody ended up having plasmid change. Now it has changed a lot. So it is challenged to diagnose HOS from other causes. Discontinuation of C5 blockade is feasible in some patients with pregnancy and postpartum atypical HOS. And the new positive message is that pregnancy is no more contraindicated in patients with a history of atypical HOS, but it still remains a high-risk pregnancy. Thank you.
Well, thank you very, very much, Fadi. I think we've learned a lot, and this was a wonderful webinar. So as usual, I'm waiting for your questions. We do have time, and let me start immediately by I'm opening the questions here. So apologies, I don't know what. Okay, so anyway, okay, my apologies, I cannot read your name, so I will simply read the question. So the first question is whether cortical necrosis, is it always bilateral?
Whether it is always?
Bilateral. Is cortical necrosis always bilateral?
Yeah, in this setting, yes. In this setting, yes. It may be more or less complete on one side compared to the other, but it's very, very unusual to have unilateral renal cortical necrosis in setting of postpartum hemorrhage because bleeding is everywhere, and the precipitating factor in some patients of long duration of tranexamic acid has no reason to go on the right, not on the left. So usually, yes, more or less complete, but usually I haven't not seen a case with unilateral.
And the question was actually from Lucille Figueres. I now can read your names. Marie Hilderman is asking, is existing diagnosis of autoimmune disease a risk factor? So if patients have autoimmune disease, is this a risk factor for atypical HOS?
Which one?
Autoimmune diseases.
For atypical HOS, no. I would say ADAMTS13 deficiency related to autoantibodies is closely associated to autoimmune disease before or after the onset of TTP, but atypical HOS, no.
All right, so Nicole van der Kar is asking you, how do you explain the high C5b9 when complement block is blocked? And she's wondering which assay have you used?
Yeah, Nicole, I have to check with Veronique. I think we used a commercial available from Quidel, but I will answer your mail, but I didn't have time to catch with to discuss with Veronique. I think that in some patients, the drive of complement activation is so important and so potent that despite eculizumab, you still have some form of C5 activation. And as you know, there is a lot of discussion whether non-C5 convertase dependent pathways may lead to C5 activation. So I assume that is the drive for complement activation is so important in some patients that despite eculizumab, you may still have soluble C5b9. The question is also why you still detect soluble C5b9 despite eculizumab, even not very high, but even detectable. What is a little bit disturbing is that even patients with no complement gene variants, some of them still have some increase in soluble C5b9. So I don't have a clear answer. I assume that it is the importance of the genetic or the genetic drive of complement activation.
All right, so you have a lot of questions. So Fadi, if we want to go through all of them, try to be. So Dr. Suhair Asaidi is asking you, is first thanking you for the great talk. Then he's asking you, what is your protocol for Soliris in pregnancy? And he has a second question, do you have experience with Ultomiris in pregnancy?
No, I have no experience with Ultomiris in pregnancy. And in the postpartum is another issue, but during pregnancy, I start with a regular regimen and I increase the dose and shorten the interval to have a CH50 below 20%. I don't have a very specific or any recipe. It depends on patient, but I start with a regular regimen.
So let me maybe follow up on these questions because this is something I was wondering. If you have a patient that had one episode of atypical HOS where you haven't found any mutations, where you have taken the patient off eculizumab and is doing perfectly fine, and the patient comes to you and tells that she's going to have a pregnancy, do you start that patient on eculizumab?
No, at least what the working group recommended is no prophylactic eculizumab, and I have to admit it was my opinion too. It's very unpredictable, and I think that the close monitoring, even during the first months of pregnancy until 3 months postpartum, is more cost-effective than giving a prophylactic eculizumab. The risk during is not like renal transplantation, and as you know, the Dutch experience, even with renal transplantation with no prophylaxis, is very interesting and promising. No, we did not suggest doing prophylactic eculizumab, even if the patient had a pathogenic variant. Close monitoring and rapid treatment, but no prophylactic.
Okay. So Dr. Malek Moyat is asking you the following. So there are 3 questions. I think it's the same question in 3 pieces. So let me just read them to you. In a patient with a history of atypical HOS prior to pregnancy, when she presents again with TMA, do you use eculizumab directly or do the same workup? I guess similar to the question that I just asked.
Yeah, no, I think it's prophylactic, or if she has TMA, we do not do differential diagnosis and go straight forward for eculizumab. I don't understand the question.
Yeah, neither do I. So please, Dr. Moyat, if you can write us again and specify your question. So Dr. Kathleen Klaas is asking you, why do you use the cutoff for ADAM13 of less than 20% in pregnancy and not 5 or 10%? ADAM13 goes down during pregnancy. What are the normal values at the end of pregnancy?
Yeah, I totally agree with her, which is discussed in the paper. Of course, ADAM13 decreases during pregnancy, but it's never undetectable. And it has been a debate, there has been a debate between experts in ADAM13 from France, UK, US, and even Switzerland to choose a cutoff. What I've learned from this expert, that is, the number of patients who will be between 10 and 20% are so slow that is more a theoretical discussion than anything else. But in some countries, I agree with her, it's more 10%. In France, it's more 20%. In other countries, it's 5–10%. I agree, but this is what the consensus went for, it was 20%. So you have to rely on, I would say, the threshold of each lab.
All right, so Dr. Peter Barani is commenting that there is still a problem with differentiating most severe cases of preeclampsia and HELLP syndrome and atypical HUS in the initial period. The obstetrician do not recognize this patient as typical HELLP syndrome preeclampsia. And the question is the following: do you allow breastfeeding for patients on eculizumab?
It goes in milk in my recollection, so I won't do it. But I think that the most wide experience is in the hematology with PNH. I would say yes. Why not?
Yeah, I would actually answer the same thing personally. Just for everybody, we still have a lot of questions, so please do not send more questions because I will not have the time to ask them all. So Dr. Moyat wrote again. So if the patient had a history of atypical HUS and now presents with a TMA during pregnancy, do you use directly eculizumab, or you rule out the other differentials like the diagram you've shown? Again, thanks for the great presentation. And please don't send
easily. Sorry, I interrupted you, sorry. I will go more easily and more rapidly to eculizumab, of course. Like any recurrence of TMA in a patient with a history of HUS will go more easily and more rapidly to C5 blockade. But still, it's a very tricky situation. The patient may have the CKD, more or less the CKD, and still present with preeclampsia or eclampsia. So it's not very straightforward. But of course, it will help go more easily and more rapidly to anti-C5 blockade. Clearly.
Okay, Dr. Enrique Morales is asking you whether you would consider eculizumab in pregnant women with preeclampsia before 30 weeks of gestation. What is your opinion about the use of measuring levels of eculizumab?
Okay. First, I would not use it. I never used it. I use eculizumab in preeclampsia and eclampsia. Maybe I'm wrong, but I haven't done it. And the evidence that preeclampsia, eclampsia is predominantly related to complement is not so high. And the fact that HOS patients treated with eculizumab do not relapse, do not have HOS relapse, but do present preeclampsia eclampsia is a not very strong argument for the use of eculizumab. To be honest, I've done it twice in HELP syndrome, very severe HELP syndrome, that did not resolve after 7-10 days of monitoring, 1 or 2 infusions. But once again, with no very hard evidence clearly. I don't remember the second question. The trough level, the levels of eculizumab. I would say why not, but it's very tricky to see what is the trough level, the optimal trough level during pregnancy. You have a distribution volume which is very increased. You have probably an increase in C5 synthesis. So a trough level that is very potent to control complement activation outside pregnancy is not necessarily very accurate to control complement activation during pregnancy. I would stick to CH50 despite all its limitations.
Okay, so Dr. Evelyn Silo is asking you whether you switch patients from ravulizumab to eculizumab in the event of pregnancy.
This is a very good question, and probably it will be it's a question that will be raised more and more with the use of Ultomiris. If the patient is stable, I will keep it on Ultomiris once again, because we do not do prophylactic eculizumab. At least we do not recommend prophylactic eculizumab. Switching from Ultomiris to eculizumab just for pregnancy maybe is too much. But if, this is my personal opinion, if a patient has a TMA during pregnancy, probably I will start with eculizumab to control the situation for a couple of weeks and then consider using ravulizumab later.
All right, so Federica Tomatis is asking you whether you could specify the right answer to the question that you've changed. So you had that question where you say answer if you have a typical HOS, but she's asking you what was the right question answer to the question of pregnancy-related TMA. Okay.
So I changed the question, and I apologize because it was too vague. If it's ATHA, if you diagnose pregnancy and post-op atypical HOS, in my point of view, the right treatment is anti-C5. It is C5 blockade. Once again, as I already said in one table we wrote in the consensus paper, plasma exchange is supposed to be a magic solution to a lot of conditions in medical settings, especially in very stressful situation of pregnancy and postpartum. But outside anti-ADAMTS13 antibodies related TTP, there's no proof, no evidence that is helpful for patients. If we do plasma exchange just to do something and reassure ourselves and the patient, in my point of view, it's useless.
Perfect. So Martin Dox is asking you, when is the best time to take blood sample for genetic pathogenic complement factor analysis after delivery?
What is the blood test? I don't understand.
The genetic testing.
Yeah.
What was? How long do you wait to perform the genetic test?
I perform it right away, because the time you spend to get the results is very variable. So what we usually do, we start eculizumab, we do the genetic test, and when you stabilize and recover the maximum you can of renal function, and you have reached a plateau around 3-4 months, you are going to start discussing with the patient whether you stop or not, and you need a genetic test. The second point is that detecting a pathogenic variant in complement gene is retrospectively, if you want it or not, an argument for complement-mediated ATP-HUS. It's not very reliable as a positive test, but if you get a complement gene, pathogenic complement gene variant, it will confirm retrospectively your diagnosis. So it's helpful also for the diagnostic retrospective.
All right, so Fadi, we still have 5 questions and 9 minutes to go. I don't know whether you can answer the next question because it's a very generic question. So Dr. Fadi Haidar is asking you whether you had cases with a relapse after kidney transplantation with or without a pregnancy after transplantation, and what is the percentage of relapse?
You mean, wait, it's very, of course, you have relapses after renal transplantation. The highest is with the patients with very pathogenic complement gene variant, and the lowest, of course, with no pathogenic renal variant. And this is also true for some patients who lost their kidneys from pregnancy and postpartum HUS before the eculizumab era. Yeah. Yes.
All
but
right.
Once again, the relapse after complement discontinuation is very similar to the relapse after renal transplantation.
All right. So Dr. German Munoz is asking you how do I realize I make the diagnosis in the case of a patient that has no thrombocytopenia?
Kidney biopsy. Kidney biopsy.
Okay.
Will give you an indication. It's very rare, but I said it should not rule out. It may be very transient and correct itself very rapidly. Usually it's kidney biopsy. And during pregnancy, it's very rare because, as you know, platelet count decreases during pregnancy, even in normal pregnancy. So you are starting with a rather low level. That's why it's more frequent outside pregnancy, but you have to keep it in mind.
Okay, so Dr. Jorge Royas Rivera is asking you, what is the prognostic value of C5b9 deposition in renal glomerulus during treatment with eculizumab? Does this marker has a correlation with serum C5b9 determination?
I have no experience, but all I can tell you is that based on what has been published, for example, in lupus nephritis, where soluble C5b9 staining in the kidneys persists for weeks and months and even years after the remission of the disease. That does not correlate with the activity in lupus nephritis, where complement activation is obvious for everybody. I will not use it as a very reliable test. If you have very severe hypertension, let's say malignant hypertension, in the setting of preeclampsia, PRES, or with the PRES syndrome, if you have some soluble C5b9 on your vessels in the kidney biopsy, it would be hardly surprising. The in vitro tests are a very promising approach, but it's too early, in my point of view, to draw firm conclusions. It was a very excellent idea by Remuzzi and Marina Nuri's group. It has been duplicated in Spain and in the Netherlands, but you need to have the result duplicated in other labs before it is implemented and see how it will change our clinical management. But in the time being, in my point of view, clinics should prime and should be more important than all the other tests while we wait for confirmation.
All right, Kathleen Klaas is asking you another question. Do you advise the genetic testing of female family members, for example, the daughter of a patient with a factor H mutation, in order to be able to quickly act at time of atypical interest during pregnancy?
Excellent question. It has been discussed in the paper too, and there was no consensus, but it was a rather no, for 2 reasons. In some countries, it's not allowed. The second is that the risk of, even if you have ATP-HUS, or if you have a pathogenic variant, the risk of occurrence of HUS during pregnancy is highly unpredictable. And third, since the publication of our paper, Santiago de Cordoba's group have published on the risk of HUS relapse in general in healthy relatives of HUS patients. and these relatives are carriers of pathogenic variant, and the risk was very, very low. I would say no. To know that there is a history of HOS in the family is already a big information. It will help go maybe more rapidly to the diagnosis, but in some cases, it may be lead to the overdiagnosis of atypical HOS. Maybe it's simply preeclampsia. I would say no, but it's on a case-by-case basis.
All right. So the last two very, very quick questions. Dr. Alexandra Vornico is asking you, is it frequently encountered during pregnancy, TMA secondary to malignant hypertension?
No. I would say it's a complex situation because you may have atypical HOS and malignant hypertension. You have to keep in mind that one of the causes of malignant hypertension is atypical HOS. But yes, I have seen a couple of cases of fibrodysplasia renal artery stenosis during pregnancy. Yes, it may occur. It may occur. You have to keep it in mind. And usually these patients are treated from their renal artery stenosis, for example, before pregnancy or in view of pregnancy.
Perfect. And then the very, very last question. Any data on the development of anti-hycolizumab antibodies in your experience?
No.
That was from
no.
Dr.
Honestly, I do not have any experience. And I'm not aware of any case of neutralizing anti-hycolizumab antibody.
Well, thank you again for this wonderful webinar, Fadi. That was really very interesting. You had a lot of audience and people were very interested, and it was a wonderful listening to you. So before leaving you, let me remind you the next webinars. So in 2 weeks' time, Ben Walsh will talk to us about distal RTA. And then again, complement with Christoph Licht in February with C3 glomerulopathies. And again in February, paraprotein-associated disease. So 3 very interesting webinars. Please join us again. Thank you very much and have a good day.
Bye-bye.
Bye.